Good afternoon, everybody. Welcome towards today's topic is obstructive airway disease. What is the obstructive airway disease? Obstructive airway means there is an obstruction in the airflow, not any mechanical obstruction or any interluminal obstruction. And we divide in two types. One is the COPD and asthma, depending on the pathogenesis. And today we will discuss the COPD. COPD, the full form is chronic obstructive pulmonary disease. Now it is going to be the fourth leading cause of death in the world, and after 2020 it is assumed that it will be in the third position of the total death among all the diseases. And globally the COPD burden is projected to increase in coming decades because of continued exposure to COPD risk factor and aging of the population. Now the prevalence of the COPD, and it is estimated that the global prevalence is around 11.7% among the whole population, and annual death is counted around 3 million per year. Now come to the what are the risk factors. The risk factors are mainly there is a environmental exposure to the smoke, either in the form of active smoking, passive smoking, and burning of the biomass fuel. So we divide it in exposure to the tobacco smoke, this is the leading cause. Then biomass fuel or in the open fires, that further causes smoke production and also causes injury to the airways and alveoli. And there is an uncontrolled asthma, initially which was reversible, and due to the uncontrolled, now there is a sufficient remodeling, or there is some changes in the airways that convert this asthma towards a COPD like feature, or we call it asthma COPD overlap syndrome. And exposure to the occupational dust and chemicals, and this causes further damage to the lower airways, particularly the terminal bronchiole and alveoli, and also the infection, overcrowding and damp. This is the infection in form of tuberculosis, pulmonary tuberculosis, one of the leading cause of COPD in our country, and also the low socioeconomic status. Now come to the host factor. Host factor is the most one, very important. There is the alpha-1 antitrypsin deficiency. Actually, this is the anti-protease activity of this disease is decreased, so that there is an increased chance of protease activity that is caused by inflammation, and that causes bronchial hypertrophy. There is a chronic bronchitis, and also in the alveolar destruction or emphysema. Hyperresponsiveness to the allergen that leads to the asthma, and uncontrolled asthma ultimately turned into COPD. Then lung growth and advanced stage. Now COPD definition. The COPD definition is COPD is a common, preventable and treatable disease, and that is characterized by persistent respiratory symptoms and airflow limitation that is due to airway and or alveolar abnormalities. On the right side you see that there is a healthy airway, and on the left side, there is the healthy airways. On the right side, there is a airway with persistent bronchitis. There is a mucosal thickening, and also there is a muscular thickening, and also there is a mucus production. So the inflammation and the excess sputum. And at the same time, one is the this is the bronchitis, and as the emphysematous variety, where the air sacs with emphysema, that is the destruction of the assignee, and the air sacs are destroyed, and it causes the persistent symptoms, that is the exertional dyspnea. Now, how this bronchitis or COPD or emphysema, how it occurs? Pathogenesis is the environmental exposure to smoke, biomass fuel burning, that enters into our respiratory tract and causes inflammation, which ultimately leads to the increased activity of neutrophils and other cells, and which produces the elastase and cytokines. And this elastase and this production of the cytokines, this ultimately causes to the airway remodeling and cellular infiltration, and on the assignee it causes loss of alveolar attachment and decreased elastic recoil, and ultimately leads to the airway limitation. Now, what are the remodeling or the airway pathogenesis? What are the changes that occurs after exposure to the smoke? There is a mucosal gland hypertrophy, smooth muscle hypertrophy, goblet cell hyperplasia, inflammatory infiltrates, excessive mucus, and squamous metaplasia. Now you can see there is a parenchymal pathology. Now on the right side there is a destroyed alveoli, and there is a alveolar. Now on the left side there is a normal, and right side now see that there is a destruction of the parenchyma, and also there is a alveoli that is filled with air. Now COPD that includes the two variety. One is the chronic bronchitis and another is the emphysema. But most of the patient either of the variety is predominant, and you can say that there is a chronic bronchitis and emphysema varieties are almost mixed with each other in most of the patient. Now what is the definition of the chronic bronchitis? It means the chronic productive cough for at least 3 months in each consecutive 2 years in a patient in whom the other causes of chronic cough have been excluded. Other causes of chronic cough means we have excluded there is the bronchiectasis and pulmonary fibrosis or parenchymal fibrosis. And the emphysema, by definition, there is the abnormal and permanent enlargement of air spaces distal to the terminal bronchioles, and that is accompanied by destruction of the air space walls without obvious fibrosis. Now come to the subtypes of emphysema. We already discussed the pathogenesis. Now subtypes, there is the centrilobular emphysema, and there is the dilatation of the respiratory bronchiole. Now you see there is a depicted in the picture. This is the respiratory bronchiole that is the dilated due to the pathogenetic mechanism, and there is the central portion of the acinus, and mostly commonly associated with the cigarette smoking. Now pan-acinar emphysema, that means total of the acini is involved, and there is the enlargement and destruction of all parts of the acinus. Now you can see the respiratory bronchiole, alveolar duct and alveoli all are involved, and mostly it is associated with the alpha-1 antitrypsin deficiency and in smoker. And on radiologically you can see there is a lower lobe involvement is predominant and younger age group, as it is genetically alpha-1 antitrypsin deficiency involved. So the COPD or bronchitis feature that occurs very early. There is a early in the 4th decade of life, and it is more predominant in male, and CT scan shows the lower lobe predominance. Another is the paraseptal emphysema, or also called the distal acinar. Here the alveolar ducts are predominantly affected. Now you see there is the alveolar duct, this portion is involved. And at the same time there is a acinus that is surrounding the pulmonary vasculature. Whenever there is destruction of the alveolus, and there is associated with the destruction of the pulmonary vasculature, and which ultimately turns out to be chronic hypoxia, there is a VQ mismatch and leads to the pulmonary arterial hypertension. So the intimal hyperplasia and smooth muscle hyperplasia thought to be due to the chronic hypoxic vasoconstriction of the small pulmonary arteries, and destruction of the alveoli due to the emphysema lead to the loss of the associated area of the pulmonary capillary bed and pruning of the distal vasculature. And this pruning of the distal vasculature there is obvious in chest X-ray. Now what are the symptoms of COPD? And now the symptoms are collectively both of bronchitis and also the emphysema. And in case of the bronchitis there is a cough and sputum production, and usually there is a mucoid sputum, and whenever there is an infection it becomes mucopurulent. And whenever the patient is suffering from predominant emphysematous variety, there is a chronic progressive shortness of breath, and also we get, because of persistent airflow limitation, we get the wheezing and chest tightness. Now what are the physical signs? In case of, now we are discussing a patient with chronic stable COPD, so he is not in the acute exacerbation. So what are the physical signs we will seen during inspection? We already discussed this, the barrel shaped chest during anatomy and physiology also. There is a use of accessory muscles of the respiratory are in use, prolonged expiration during the quiet breathing, and expiration through the part sleep. And by the expiration through or part sleep breathing, that means it increases the expiratory portion of respiratory cycle. Expiratory time of respiratory cycle. If you can remember the IE ratio, that is normally 1:2. In case of the COPD patient, they have increased the expiratory phase so that they can take the expiratory phase or expiratory time just to exhale the carbon dioxide, remove the carbon dioxide. Now paradoxical retraction of the lower interspace during the inspiration, or there is the Hoover sign and the tripod position. And now you can see in the picture on the right side this is the barrel chest. Now see that this is the anteroposterior diameter, and anteroposterior diameter now becomes almost equal to the transverse diameter. Now the tripod position. This tripod position is another position so that you can assume that the patient is also suffering from some respiratory disease, particularly the COPD. And in this position, patient just relieve the dyspnea by leaning forward with arms outstretched and weight supported by the palms and elbows, so that the accessory muscles of the inspiration and expiration can be used. What are the clinical features or the clinical signs you will see? On the palpation, there is a decreased vocal femmitage. On the percussion, there is a hyperresonant note, and there is obliteration of the liver dullness. And diminution of the area of the absolute cardiac dullness, though the cardiac percussion not done now. And auscultation, there is a prolonged expiration, the expiratory phase is prolonged, and reduce the breath sound because there is a airflow limitation and there is a reduce in the size of the airways, and presence of the wheezing during the quiet breathing, and crackles can be heard if the infection occurs. Now come to the diagnosis. How to diagnose the patient with COPD? First one, analysis of the symptom, then analysis of the exposure to the risk factor, and spirometric measurement of the airflow limitation. So the patient presents with the shortness of breath. There is a chronic, there is the, we call it, there is the exertional dyspnea, and that is chronic, associated with chronic cough and sputum production. And exposure, and patient is a male, usually male patient, and associated with some type of smoking. There is a tobacco smoking, and occupational exposure to the biomass fuel or any environmental smoke, and indoor and outdoor air pollution. And this is the spirometry, and this is spirometry lab, and by the spirometry you can just require for diagnosis, and there is a fixed obstruction, we can diagnose. There is a presence of post bronchodilator value of FEV1 by FBC. There is the absolute value 0.7 that confirms the presence of persistent airflow limitation. So we can diagnose the COPD by lab test. And depending on the post bronchodilator FEV1, we categorize into the following 4 types: gold 1, gold 2, gold 3, and gold 4. And we can first we have to diagnose is the FEV1 by FBC value, that is less than 0.7. This is the absolute value, and depending on the post bronchodilator FEV1, we can categorize into the mild, moderate, severe, and very severe. What is the mild disease? That is the FEV1 is more than 80% of predicted. Moderate, the FEV1 between 80 to 50%, severe between 50 to 30%, and very severe, there is the FEV1 is less than 30% of predicted value, and predicted value is calculated by the software of that machine according to the height, age, and sex of the patient. Now come to the chest X-ray. What are the chest X-ray? Particularly in bronchitis chest X-ray, we do not find any remarkable changes, but in the emphysema there is a marked hyperinflation of the lung field, and there is flattened and low diaphragm, and there is the intercostal spaces become widened, a horizontal pattern of dips, and the heart shadow, there is the very tubular, and there is a decreased marking in the peripheral vessels, that is we call the pruning of the vessels. Now comes to the management. Then how will you treat the patient? The principle of the treatment is prevention of the further progression of the disease, preservation and enhancement of the pulmonary functional capacity, and avoidance of the exacerbation. And avoidance of the exacerbation, this is also very important, because whenever there is exacerbation, that reduces the FEV1 of 50 ml per year or per exacerbation. Now mainstay of the treatment is the bronchodilator. So bronchodilator are the central to the symptomatic management of the COPD, and it improves the emptying of the lungs, reduces the dynamic hyperinflation, and improve the exercise performance. Now what are the bronchodilators available? What is the beta 2 agonist? There are short acting and long acting. Short acting salbutamol, tarbutamol, long acting salmeterol, formoterol, and indacaterol. And anticholinergic, ipratropium, tiotropium, and newer anticholinergics are there. There is the glycopyrronium. and theophylline. There is a xanthine inhibitor, there is a weak bronchodilator, and which may have some anti-inflammatory properties also. And the glucocorticoids we use either in the inhaled form and also in the oral or IV. And the inhaled glucocorticoid is appropriate in the symptomatic patient when the FEV1 is less than 50% of predicted value. And chronic treatment with the systemic glucocorticoids should be avoided because some unfavorable risk. Now come to the combination therapy. So initially, to start with, we divide the patient or the COPD patient into the 4 types A, B, C, D. I will discuss it later on. And according to the patient profile, we have start with the only bronchodilator. It may be the short acting and it may be the long acting. But if the patient FEV1 is supposed to be less than 50% and there is chance of frequent exacerbation in a year, and with some other clinical features also suggestive there is a possibility of frequent exacerbator. So in this situation, we add the inhaled corticosteroid along with the beta 2 agonist. Now the therapy with the long-acting beta 2 agonist and inhaled corticosteroid shows a significant additional effect of pulmonary function and a reduction in the symptoms. Another is the phosphodiesterase 4 inhibitor, and their use is very limited, particularly those patients of the COPD shows predominant bronchitis feature, chronic bronchitis type predominant feature like your cough, mucoid expectoration. So in this situation, we use the roflumilast. That reduces the exacerbation and also the use of the glucocorticoids. The two major side effects of the roflumilast is weight loss and GI disturbance, particularly diarrhea. So whenever we use the roflumilast in a patient, we have to inform that there is a possibility of weight loss and diarrhea after a sufficient period of time. Now come to the ABCD assessment tool. This is very important because as per the GOLD guideline, and GOLD guideline is the guideline that entails about the treatment protocol, diagnosis, treatment protocol, and also the preventive measures. So what we have already been discussed, there is a spirometry. The spirometry that confirms the diagnosis. So whenever a patient comes with the exertional shortness of breath, or there is a frequent cough and expectoration that persists for a long time, and this is a male patient and have exposure to the smoke, or is a smoker, or is the environmental exposure of the biomass fuel, or any history of any infection like COPD, and there may be possibility of alpha-1 antitrypsin deficiency in a subset group of patients. So in this situation, we thought it is a case of COPD, and we diagnosed the COPD by spirometrically. There is a fixed airflow limitation that is diagnosed by FEV1 by FBC value that is less than 0.7. And according to the FEV1, we divide or classify the patient according to the GOLD 1, 2, 3, 4 according to the post bronchodilator FEV1 value. Now the patient come with the assessment of the airflow limitation that is already done by post bronchodilator FEV1, and assessment of the symptom or risk or exacerbation that is done by the following criteria. So we have the COPD assessment test is there. There is a subjective test, and patient has been given to some questionnaire, and the number of the questionnaire, every question has some marks, and the number increase in the marks that increases the chance of exacerbation. And modified medical research council, that is the MMRC scale, that is the scale of the dyspnea. So we divide the patient according to the A, B, C and D. On the right side, there is a MRC scale is more than 2 and CAT score is more than 10. That is a most high risk group for frequent exacerbation. On the left hand side, there is a MRC score 0 to 1 and CAT score less than 10. And depending on the situation or depending on this categorization, we we can formulate the treatment of this patient. Now today we will discuss mainly the treatment of the stable COPD patient. So stable COPD, what is the group A patient? This is already discussed. We need only bronchodilator. Group B patient, that means there is a more increased risk of exacerbation. So MRC scale is more than 2 and CAT score is more than 10. And here we use the LABA or LAMA, long-acting beta 2 agonist or long-acting anticholinergic. Either we use the formoterol or associated glycopyrronium combination is there, or we can use the glycopyrronium as a single drug. Now come to the C. There is a long-acting anticholinergic either in the form of ipratropium or there is a glycopyrronium. But here if you see the post bronchodilator, if it is suggestive of less than 50% and there is a chance of frequent exacerbation, so we can use the inhaled corticosteroid along with the LAMA. Or the group D patient, this is a very high risk patient or the frequent exacerbation, so we use either LAMA-LAVA or ICS beta 2 agonist, or there is an anticholinergic Salon. And here one thing, there is the highly symptomatic patient, there is a category 2, the CAT score is more than 20, and there is a eosinophil count, there is a blood eosinophil count more than 300 per microliter, so we should use the ICS and LAVA combination. And these are mainly the pharmacological treatment of the COPD. There are some non-pharmacological treatment, and mostly we rely on the smoking cessation. And the smoking cessation, now the study shows that the smoking cessation that improves the quality of life, decrease the exacerbation and decrease the infection, and that greatest capacity to influence the natural history of the COPD. And pharmacotherapy for smoking cessation, we use mainly the nicotine replacement therapy. And what are the medicine available? There is a nicotine replacement therapy, there is a nicotine gum, either nasal spray, transdermal patch, sublingual tablet or lozenge. Or other drugs are available such as varenicline, bupropion, nortriptyline. These are also been useful for long-term smoking abstinence. Now, what are the complications of the COPD? The first one is the respiratory insufficiency and or respiratory failure. This is a major and life-threatening complication. Patient may need sometimes mechanical ventilation also, just to reduce the hypercarbia, maintenance of the pH, and also to control the infection. There is the second one is the pneumonia, respiratory infection, right-sided heart failure, or patient may develop cor pulmonale, pulmonary hypertension, pneumothorax, and skeletal muscle dysfunction. It occurs due to the inflammation itself and also the long-term use of oral corticosteroid. And depression and anxiety is another common factor that complicate the disease. Now, what are the comorbidities that are associated with the COPD? Mainly the anxiety, depression. In the lung, we got the lung cancer. There may be possibility of the sleep apnea, pulmonary hypertension, cardiovascular, particularly the ischemic disease. Ischemic heart disease are very common, and peripheral muscle wasting and dysfunction as a result of the inflammation itself, and also due to the side effect of the steroid, and osteoporosis due to the disease. This is the decreased mobility of the patient and side effect of steroid. Peptic ulcer and GI complication due to the drug, particularly the xanthine group of drug, and also the steroid and sometimes beta 2 agonist. And there is a diabetes and metabolic syndrome. These are also been associated with the COPD. So whenever we are treating a patient with COPD, we should always take care of these comorbidities, because comorbidities has influence effect on the COPD exacerbation. So whenever we treat the patient with the COPD, we optimize the treatment of COPD. At the same time, we have to control over the comorbidities. Thank you for patient hearing.